I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Thank you for joining me this week for another episode of Fridays with Faisel. I believe that everyone deserves access to quality primary care and should be treated the same, regardless of their ability to pay. This week's topic is physician-centered innovation. My father is a retired inventor from AT&T Bell Labs. That's a place where they invented the silicon chip. Over the weekend, I quickly Googled and found about a dozen of his patents, with voice recognition, flash memory, even caller ID. And for many of his patients, especially the ones for many of his patents, especially for the ones where you had a human being talking to a computer, the hardware and the software didn't even exist yet. We're talking about like before Pentiums, there were 486, 386, 286, before all of that. And they still ended up making it happen. So I called him over the weekend. I said, Dad, what was the driver? Was it money? And he started laughing. He said that his intellectual property belonged to AT&T and that he only received a one-time payment of like $1,000. After taxes, you're talking like 600 something bucks for each patent. And he said that necessity is definitely a factor with innovation, but what drove that group of people, that group of engineers, was passion. And when he said that, that really resonated within me. And I believe that the innovation in healthcare today is being driven by a lot of the kind of work that companies like ChenMed are doing with the full risk model. So without further ado, I'd like to welcome my co-host, Robert Longyear.
Hey.
Robert,
Hey,
Robert, how you doing?
I'm doing well. How are you?
I'm doing really well. Look, really excited about this topic this week. I'm excited about the guests that we have, and and after last week was a big week because towards the end of the show we realized that we had like over 50 comments.
Yeah.
And so how to properly engage the comments? We really want to have the audience participation, really start to bring them into our discussion.
Mm-hmm.
And I thought, who better to help keep manage the comments, respond to the comments, bring people in and out? Who would be really good at even interrupting whatever we have going on? Who has the skill to be able to do that other than my mentor and father figure, Dr. Dan McCarter. Dr. Dan, thank you so much.
Absolutely.
I can't believe it. I appreciate it so much.
It's great being here with you, Faisel. I look forward to learning more about innovation and helping you with the comments.
Super. And are you ready? I think we should introduce our guests that we have this week.
So why don't we introduce a little bit more where innovation might be going on first? And I think we have a really nice graphic that we can pull up here.
That's right.
So when we think about innovation that's going on in healthcare, I think the main three areas that are being focused on by physician innovators, by other innovators, are trying to solve the problems we have in the country surrounding cost of care. Our total cost of care in the United States is significantly higher than other developed nations with similar patient populations and similar health systems. Our health outcomes in a lot of different conditions, a lot of different patient populations are significantly worse. And, we don't manage chronic illness very well, which is something that is perhaps due to our lack of investment in primary care, which is something we talk about a lot on this show. And then the experience with care. Patients, we're all patients, we've all been patients. And I think we can all agree that going to see your doctor a lot of times in most settings is not a great experience. You spend a lot of time in the waiting room. There's a lot of paper forms you have to fill out each time. your multiple doctors don't talk to each other. And so a lot of the innovation that's occurring in healthcare are trying to affect change in these three areas. So we can get rid of that now. In the world of becoming a physician or getting interested in healthcare, I think people get into it because they truly want to do good. They want to help patients and the whole society achieve better health. But in our current system, the way things work, we see a lot of people burning out, a lot of clinical staff, a lot of physicians, and a lot of people who get into the system and are really, really disheartened by what they see. So innovation is a way that we can try and fix those problems. From payment innovation to technology innovation, there's a lot going on in healthcare right now. But a lot of times when you think of innovation, things go to the high tech. We think about digital, we think about virtual care, we think about telemedicine, we think about artificial intelligence. And all of these things are going to transform healthcare going forward. But there's also simple innovations that can occur, simple things that can change a little bit of what happens at the patient level that really impacts quality of care, that really impacts cost. And I know ChenMed is a master of a lot of these simple innovations that really make big outcomes for them. So I think, Faisel, let's introduce our first guest.
Yeah, let's do that. So I'd love to introduce Dr. Aymara Fernandez. Welcome, Dr. Aymara.
You're on mute.
Oh, thank you. Hi, good afternoon. Thank you for having me today. I'm very, very passionate about primary care and preventive care, so very happy to join you today.
Super. Dr. Aymara is one of our primary care doctors and medical directors from our Miami market. So when people are saying things like, well, you know, the full risk model really only does well with healthy patients, people who don't have issues with transportation, only English speaking and all. It's nice to have a doctor saying, okay, you guys are all talking this stuff, but here, let me tell you what the full risk model is really like. So thank you so much, Dr. Aymara. And she's in the middle of her clinic. I see that you're in one of the exam rooms. I mean, just in between seeing patients. Thank you so much for joining us today.
Absolutely. Thank you.
Wonderful. And also we have today joining us Dr. Uli Chettipally. Dr. Chettipally, thank you so much, or Dr. Uli, thank you so much for joining us today from San Francisco.
Thank you. Thank you for having me, Faisel and Robert. You can call me just Uli, so drop the doctor. I'm really excited to be here because this is one of my favorite topics.
I'm a huge fan of yours, especially on LinkedIn. I love the messages that you send out. They're always thought-provoking. And I felt let's shoot him a message. I shot you a message over the weekend, it was, saying, I'd love to have you come talk about some of the innovation in healthcare this week. And you were just so flexible and nimble. Thank you so much for joining us.
Yeah. So Dr. Chettipally, Dr. Fernandez, I'd like each of you to take a minute and talk about how you see healthcare right now, how it's changed from when you started out and becoming physicians in medical school, and what you're hopeful for going forward. So why don't we start with Dr. Fernandez?
Absolutely. Thank you for the opportunity. So I love to take life in that manner. You know, where were we? Where are we? And where do we want to go? And I can tell you that I'm very privileged to be a doctor who works in a hopeful place. We are making change to lead America's primary care. Where we were in the past, I trained in an institution in Philadelphia where we believed of serving the underserved. But we saw and we witnessed all these challenges. And that was part of the past. I was able to witness lack of access to care, lack of health insurance, lack of access to transportation. I saw that in the past in the eyes of a medical student. And as a doctor, I still see that today. But what I see today is that I'm privileged to work in an institution that say healthcare involves social determinants of health. It involves restoring that, I'm stealing one of Dr. Said's quotes, restoring that physician-patient relationship and addressing the socioeconomic factors that impact access to care. If you don't have transportation, how can I, as your doctor, make that not just your problem, but my problem as well, and help you find a solution? So I see that in the present, but as part of an organization that acknowledges the challenges that a lot of seniors have, I see that in the future, we need to extend that kind of care, that kind of personalized concierge medicine that addresses health disparity, to more seniors. We need to be able to reach the homes of more seniors. And we're doing that today with video medicine, a combination of in-person medicine and video medicine. Tools as sophisticated as phones, but as simple as knocking in a patient door and entering the home and providing that kind of care. So I'm very lucky and blessed to be part of an organization that is kind of the answer of that. I think back of myself as that optimistic and hopeful undergrad medical student who wanted to make that difference, who wanted to be a primary care, who's an advocate for their patients at all levels. And I'm really able to live the dream, and I hope and pray continue to do so. So thank you for that question.
Excellent. And Dr. Chettipally.
Sure, thank you. For the last 30 years or so, I've been an emergency physician, administrator, and researcher. So I'm kind of a big picture kind of guy.
Right.
So when I look at the big picture in healthcare, there are only two parties that are most important. Of course, number one is the patient and the caregivers around the patient. Number two is the physician and his team around the physician, or team. And as Dr. Fernandez said, if that team is able to take care of the needs of the patient and come up with a good outcome, that is the main job of the physician and her team. Now, imagine if you take away the other things that surround healthcare, for example, insurance, or even if you take all those things out, the bottom line is these two parties have to be there. So how do we support these two parties? Obviously, one of them is the one who understands the science and understands, what goes behind medicine, right? And so we want those people, which is the physicians, to lead the innovation because they are on the front end, like Dr. Fernandez, and they understand the problems better than anybody else in the system. That's why I like physician.
Excellent. Thank you, Dr. Chettipally. We're glad to have you here. We know that you are a big proponent, one of the early pioneers in a lot of sort of analytics and a lot of digital health technologies that have been used to support physicians in their work on a daily basis. So we're glad to have you. And Dr. Fernandez, we're very excited to have you here as well. And I know that you, just like Dr. Syed, are big proponents of doing the little things that make a big difference for patients. And so I'd love to hear from all of you about something that we'll start without the tech and then we'll go to tech. So one thing that you think all doctors should do that is a small thing that can lead to big outcomes.
Hey, Robert?
Yes.
This is Dan. So we had a couple of questions come up, and I think it's on the same track of what you're talking about. So Joel asked, saying, curious to hear your thoughts on the ChenMed model. Can or will it scale down in rural settings? Roughly 65% of their PCPs is of their patients are 65 plus, but spread out over a relatively large area, and they're wanting to bring primary care back. And then Atia was asking about mobile healthcare in rural settings. And I know that we've talked about this at ChenMed. I know Faisel has some ideas about it. So, I coming from a rural practice area, it's something that's important to me as well. So I would suggest you all comment on that if you can.
Oh,
okay.
Great comments about, especially with increasing access to care in the rural setting. How can we do that with a low tech manner? And what is low tech even these days? Is FaceTime like FaceTime high tech anymore? Do we consider FaceTiming high tech? I don't think so. My 3-year-old FaceTimes his grandparents. It's not a high tech thing anymore. And I checked how much data, even 1 hour of FaceTime, how much data is consumed with 1 hour of FaceTime. And you're only talking about 200 megabytes, not like literally less than a quarter of a gigabyte for an hour of FaceTime. And when the average doctor right now is only spending about 20 minutes of FaceTime per patient per year, could you imagine what we could do if we could allow for people to have access to their doctor just using something as simple as FaceTime?
Right. So that's your simple way to extend services to people who might have geographic access issues. So there's mobile healthcare centers that might be able to travel out to rural areas and physically bring doctors there. There's a lot of buses and vans as an approach that I believe I've seen before. There's some standalone telehealth centers that are brick and mortar, and then patients can go there and then they'll actually have telemedicine with a physician that might be in a more urban area. But also with the ubiquity of smartphones and the ubiquity of FaceTime and extension of internet, which is one of the big broadband access issues in rural areas, which keeps that from happening on a larger scale, but is improving, is a really big way to do that. So Dr. Fernandez, what do you think?
Yeah, so, I like to take it back even one step behind. Is a simple phone call. Our patients have the privilege of having our cell phone numbers. And, to me, regardless of where in the world, I actually have a lot of patients that travel internationally. During the pandemic, I've had patients in Idaho, Colorado. I've gotten to know the United States pretty well through my patient's voice. And I've been able to access them in their cabins, back home, etc., through a simple phone call. Why? Because we have trust. They have my cell phone, and if they know how to get not only myself but my colleagues. And I think that simple way, is it like necessity is the mother of inventions. Well, some of my patients are like, doctor, I don't have a smartphone. It's okay. You have me. You have my voice. And through a phone, the majority of that medical diagnosis is really through history. So if I am there for you to listen to you for 10 to 20 minutes, we've already won 75% of the problem in healthcare. So that ability of ChenMed to really advocate for the physicians to be able to feel that kind of trust with their patients is my simple innovation.
Wow. Yeah, a simple phone call, something that a lot of people across the world have access to, at least a cell phone, if not a smartphone. And one thing that's important to note here is that this doesn't happen very often in a fee-for-service model. So you're able to do telephone calls with your patients because you're already in a sort of full risk situation. So you can do and contact patients and communicate with them in whatever way works best for you and the patient. Whereas in fee-for-service, the main driver of physician-patient interaction is still the patient coming into the clinic because reimbursement's higher. And so that's not a problem for you guys. Dr. Chettipally, what do you think?
Well, I would like to reiterate what Faisel and Dr. Fernandez have said. But the key is to listen to the patient. Even ask the patient how to solve the problem. They might come up with a solution that you haven't thought about. And so first thing is listening. And then listening can be in many modes. It doesn't necessarily have to be right then while you are seeing the patient. It could be that sending an email, simple as that, sending a video message, or even if you want to go a little bit higher tech, how about a text message that can go into the chart? Simple, right? But that's not easily available for everybody.
Right,
So,
and being able, go ahead.
I wanted to say that it sounds like one major step that must happen in order for innovation to take place would be to get rid of the billing system. When doctors are not concerned, like we're moving into our 11th state. ChenMed is in 10 states right now. We're moving into our 11th state, and we don't have a billing department. Our doctors are not concerned with CPT codes and RVUs. So I think that that's definitely one major factor that will free doctors, especially primary care doctors. Primary care focuses on prevention and early intervention. And the fee-for-service model does not incentivize that. There is no incentive to focus on prevention. The fee-for-service model, the reason that at least prior to COVID, half of all medical care being delivered in the emergency room setting is because the system is not incentivized to focus on prevention and early intervention. That's why half of all medical care is in the emergency room setting. And we know that the majority of visits in the emergency room setting are hemodynamically stable patients. That's why they had the fast track in the emergency rooms. That's why standalone emergency rooms started popping up all over the country, because the hospitals can bill $10,000 for $10 pneumonias that could be treated in the outpatient setting.
Excellent. Yeah. And so obviously there's a lot of simple things that can be done where you just try and re-emphasize primary care, improve communication with the patient, and empower patients to actually be a part of their care. So instead of just having a patient come into an exam room, having a physician write a prescription and say, diet and exercise, go home in 15 minutes, it's working with the patient, understanding the patient's values and what they want to do for their own health, and helping guide them on that path. Is that correct?
Exactly. Correct. It's a doctor and the patient coming together, setting a realistic goal and a plan together that's achievable, and then they move forward. And the doctor is more, especially in primary care, the primary care doctor becomes more of this primary care health coach than they do someone who's just trying to juggle all the inefficiencies in the system.
So now let's shift gears in a little bit of contrast, and let's talk about, there's a lot of high tech stuff going on. There's precision medicine. There's precision medicine with genomics. There's a lot of artificial intelligence and clinical decision support being built on top of electronic health records. What do we think about that going forward? Do we think that that's going to be helpful, or is it going to get in the way of physicians actually building that relationship? And I think what I think would be very helpful is, Faisel, if you were to talk about some of the analytics that you guys do at ChenMed. So on the back end, you have this innovation, this high-tech innovation to support what you as physicians do when you build relationships on the front end. And so I'd love to start there, and then I'd love to get Dr. Fernandez and Dr. Chettipally's take on these topics.
So if we could start off, remember, 95% of healthcare in America is fee for service. It is a transactional billing model. So when you see, especially with data and what type of data is collected, it is all collected based on that model. And sadly, the so-called quality metrics, many of the so-called quality metrics that we see in the fee-for-service system, they actually don't end up equaling good health or better health for the patients. So that's one thing. You have to shift from that frame of mind where you're concerned where the primary incentive is to generate revenue. Now, in the full risk model, the incentive is to first stabilize. I mean, when you have a panel, if you have a patient that's not stable, you need to get the patient stabilized, and then you focus on prevention. So then your goal is to get the patient stabilized, get them in the mode of prevention, and quick early interventions as early as possible. So in our world, especially in the full risk world, when we know that the number one driver of waste, especially with cost, so far as cost is concerned, it's not specialty referrals, it's not overprescribing brand name drugs when there's a generic drug equivalent available. It is unnecessary hospitalizations driven by emergency room visits. And the solution for that is the same thing of what the direct primary care guys are doing. Making the relationship with the doctor and the patient. The patients are getting into these relationships with these primary care doctors. They have a relationship. And suddenly now, when you restore that doctor-patient relationship, patients don't go to the emergency room. So they have reduction with emergency room visits because they're restoring the doctor-patient relationship. Now, in our world, we take on the full risk for the patient. So with us, we're incentivized to improve the health and reduce unnecessary hospitalizations by having a good doctor-patient relationship. We can do a lot of doctoring with just a simple phone call.
Hey, Faisel.
Hey.
Tim Kaufman brought up a few good points here when he was saying that in order to modify behavior, it's important that the patient believes three things. The patient has a shared voice and influence in the care plan. The care plan takes their specific life factors into consideration, and the patient can accomplish the task in the care plan. With that, it is plausible and possible to modify behaviors for better health outcomes. I think you would believe that, and I bet Dr. Fernandez would as well. But I just thought it was worth bringing that up, that we have some like-minded people looking at this today.
Oh,
absolutely.
Yeah, how many times in the fee-for-service world, if you ask a fee-for-service doctor, What are you being measured against? Like what is the metric that a primary care doctor in fee for service is being measured against? And usually it's something along the lines of how many patients they see every day. If you ask them a simple question about, well, what percentage of your patients are going to the emergency room? How many of your patients out of your 2,000 to 3,000? The average primary care doctor has somewhere between 2,000 to 3,000 patients. Like, what percentage of your patients went to the emergency room over the weekend? Most of them will not know. And the first response that many times we get from different even doctors who are entrenched in the fee for service world is, well, we can't change behaviors, and that's a problem. The problem in the fee for service world is just like this check the box system. The outcome is not there. The actual impact. Like if you have a diabetic, what good is it for a doctor to just tell a diabetic, hey, no sugars, no sweets, no soda, no? That's not doctoring. That's not medicine. It's about coming to a conclusion with the patient, making a realistic plan that's something that they can actually accomplish. That's a realistic one, then you help them achieve those goals.
Right. And so how can new technologies, perhaps built on electronic medical records or other tools, help achieve that goal? Can it help actually blend into the background and make doctors' efficiency and lives easier to be able to deliver on that promise to the patients?
A lot of that already exists. Dr. Uli, you're going to love this. Every single time one of our patients in the full risk world swipes their insurance card, our doctor at the emergency room, when they go over there, they swipe their insurance card, we get a text message. Your patient is in the emergency room. And then we call the patient while they're in the emergency room. We call the patient. We also call the emergency room doctor. And do you know what the response is from the emergency room staff with that patient? Oh my God, we're dealing with a VIP patient. The patient's doctor is on the phone. That is considered high-tech innovation. Now, don't ask me how that happens. Don't ask me about all the communication that needs to end up happening when the insurance card gets swiped. And I'm a very simple. I'm a doctor. We're at a physician-led organization. We're not too concerned about how it all works. We just want it to work.
Yeah, but and that's a perfect example of a pretty high-tech solution where you have a patient going to the emergency department, they're doing something over at another organization, and then you get a text. So there's a lot going on behind the scenes there to allow that to be possible to happen. And Dr. Chettipally, I'd love to get your perspective. You are an emergency room physician, emergency medicine doctor. You work in physician-centered innovation, and that seems like a pretty good physician-focused innovation right there. So what do you think about that, and comment generally?
Yes, coming from an integrated health delivery care system like Kaiser Permanente, it's very it's pleasing to my ears to hear that these things are happening. One of the when we talked about the physician being notified, one of the work projects that I did at Kaiser was to help start a call center. Patient ends up in the emergency department. How do you track that patient, especially when it is outside of the network? So to come back to the basics is, how do you get paid is so important. If that part is not there, then all the technology you have, all the tools, all the bells and whistles, even artificial intelligence, whatever it is, if you don't have this full risk-based, fully integrated way of taking care of the patient. And the reason for that is, first question, if you go to a fee-for-service doctor, is, how will this technology help me make more money or make my work less? It doesn't. If it doesn't, then it's no point, right? So the only place you would want to know the outcomes of a patient is if you want to make the outcomes better. And the only place where you can make the outcomes better and actually see the reward for that is when you have a full risk or prepaid or an integrated system like FedBank. And so whenever I talk about technology, I say, what is your business model? If you don't have the right business model, it will not work. We've seen that with telemedicine. as long as the reimbursement is there, yeah, they'll use it. After that, falls apart. We've seen that with COVID, where if your business model doesn't work, then all the elective surgeries are gone, and so the physicians have to close shop. I mean, that's a disaster. To think that physicians are going out of business because they are not coming to the office to bill. And it's a sad situation because this is when you need your physician most, especially
Right.
during the pandemic. So, those are my thoughts on it.
It's a paradox. People, the general public, will look at what's happening during COVID right now. I think this is a great point. And they'll see, oh, I thought everybody needs healthcare right now because there's a pandemic, but you're also telling me that hospitals and physician practices are going out of business. That doesn't make a whole lot of sense. And the reason for it is the fee-for-service payment model. If they're not getting those high volume, high revenue procedures, those surgical procedures into the hospitals, and they're not filling beds outside of the ICU unit, then they're not taking in revenue and they're having financial difficulties. And patients are like, I heard that there was a pandemic going on and people need more doctors. And so in certain service lines like the ICU, things have been overwhelmed in some areas, but by and large, fee-for-service payment model is really bad during a pandemic. But what you're saying, Dr. Chettipally, that I think is really important is the incentive there is crucial to the adoption of some of these technologies. So when you have, and I'm not sure who you use, Dr. Syed, or I'm familiar with some of these technologies. And the way that it works, we had a question from Paul. The way that it works typically is a claim might be filed in the emergency department, or there might be a link to the Medicare Advantage plan system. And then that data up there is then pulled into some system that then will route it to Dr. Syed. And so when the insurance company gets notified that a patient is in the emergency department, they know very quickly. They want to know that. And so then there's a system that's built on top of that to actually link that to the primary care physician. But ChenMed wouldn't care about knowing this if they were under the fee-for-service model. If they got paid no matter what happens to the patient in the emergency department, they wouldn't necessarily want to get this because there's no incentive there. But they are under a full risk model. So now their incentive is to actually keep the patient healthy, keep them out of the emergency department. And that's a big shift. And that's what's driving a lot of the technology adoption in the world today, some of these higher tech systems, because it's like, hey, I need to know this information. If I'm not in a fully integrated system like Dr. Chettipally at Kaiser Permanente, where we have all the claims, we have all the full integrated electronic medical records across the system to see what's going on with that patient. If you don't have that, and your patients might go to another organization, how are you going to know about that? And so these things are high tech, but now there's an incentive for your primary care doctor to be involved in that process because they're at risk for your care. And that's something that I think is really important to talk about here. And I do want to ask you one last question, Dr. Chettipally, while we also have you on here. Artificial intelligence. Everybody's talking about it. I think it mostly comes up with clinical decision support and risk stratification for patients. Who's at risk for some outcome, and do I need to spend more time with that patient? What does that look like? And is that something that has a place in the future of primary care?
Well, I'm glad you asked that question, Robert, because I wrote a book on it. So technology that predicts something, you want to have that only if you're going to prevent that problem. You want to know if a patient is going to have a heart attack in the next 7 days, 10 days, 1 month, 1 year, whatever. And I built those systems at Kaiser when I was there. So you want to know that only if you want to prevent it. So again, the business model, which is how is the physician getting paid, that's important.
Mm-hmm.
And we have all this data that is coming from the electronic health records, right? Some of it is garbage, but there is definitely some value in there, whether it is claims data or EHR data. So what we did at my last job was we took, let's say, 100,000 patients who had heart attacks. Let's say 100,000 patients who had congestive heart failure and ended up in the emergency. And you go back and look at those records and figure out what are the risk factors that went into this patient ultimately ending up in the emergency department. Now, if you go back and look at those records, you can actually predict, oh, this is what happened. And, the patient missed their prescription, whatever, missed the visit to the doctor, missed, a specific intervention that was needed before they ended up in the emergency. So if you know that data, then you can actually prevent, we can build models to be able to predict that in a patient, in every patient. Technology, but is very cheap when it comes to compared to a doctor's time, right? It's not expensive. The key is to have that business model, to have that foresight, to be able to fine tune a system where you're able to predict and prevent bad things from happening.
Right.
And so artificial intelligence is great, machine learning is great, but I would say you have to have those fundamentals first, which is
right. Yeah. So you can build all the artificial intelligence you want to in the world, but if there's really no incentive to actually prevent something, and the organization itself doesn't necessarily want to do anything about it or doesn't have a motivation to do anything about it, it's not mission critical, then it's just a nice flashy tool to have. So everything comes together in that sense. Dr. Fernandez, what do you think about these types of tools? You've seen, you like them? Do you think that they're nonsense? What do you think?
I think it all goes back down to that patient-doctor relationship and communication. We have some very simple calculators that help us estimate, for example, the 10-year likelihood of a patient having a vascular event in their brain or in the heart. And I often discuss these risk stratifications with my patients when I get their blood test done. So that's, perhaps not a very high technology, but predictors that we have. But it turns out in behavior that we've alluded to this in other questions today is most patients already know what they should and should not be doing in terms of what they should be eating and not, whether they should be exercising or not. And although I do like to have the data to say, hey, your risk factor of a stroke in the next 10 years, 14% if we keep your cholesterol that well. I did learn that in school. But what we learn more of at Chen Med is educating the patients to modify their behaviors. Because if I don't help you as your doctor to say, I know you shouldn't be eating that ice cream snack at night, but if I don't help you by setting up a goal, like Mr. Tim Kaufman commented earlier, if I don't sit down with a 3x5 simple note card and like, okay, so you're only going to eat ice cream 3 times rather than 5 times a week. And we're going to recheck your cholesterol in X amount of time. And our goal is for you to reduce your weight by 2 pounds in 3 weeks. If we don't break things down from, it stays at the 14% from a predictor to that like outcome in your life, then we're not going to be able to use the tools. The tools make the doctors look good. Oh, look, I know all these fancy calculators. I don't know how they came up with it, but I know of them. And I'm here to show you. But if you don't translate that into action to your patient, into simple steps, then we're not going to be able to change healthcare outcomes. And I speak as a doctor, we need better training in helping patients and ourselves modify our behaviors. So that's kind of my take on that. Take it back
even just offering solutions. I think about the neighborhoods that we exist in. So we exist in the most underserved neighborhoods and communities across the country. Many people feel forgotten in these neighborhoods by just the system in general. And I can't tell you how many times just simple suggestions to say a diabetic, things like cauliflower rice or mashed cauliflower, if somebody wants a diabetic who enjoys eating rice or potatoes or whatever, these simple suggestions that you can get from places like Walmart where it's affordable, because many people have this conception that to eat healthy or to eat well, it's expensive, it's something that's out of my reach. But when you have doctors who provide really easily understandable solutions because they have that relationship, suddenly the whole dynamic changes. The current system does not incentivize that.
Right. And bringing this all together, I think that primary care is obviously essential for health in this country. We do not invest very well in it. The models are not done very well. And some of these really more high-tech solutions for artificial intelligence, clinical decision support, might actually be a better fit for the specialties when you do have a condition that's very genetically based, or some of the cancers where you're trying to choose the best targeted treatment. And so those solutions, I think, are really, really powerful in those areas. But in primary care, it comes back to the basics. It's lifestyle behaviors, it's social and economic factors, and it's being at risk to be able to actually get involved in your patient's care. And I think that's something that we see that we need to get back to simple innovations in primary care. And a lot of other spaces, the high tech, the genomics, all of that is going to be wonderful, and it's going to be very helpful for patients. Yep.
I'll give you an example where in primary care where high tech will be useful. There are about 80 medications for diabetes, and probably 60 or more for hypertension. How do you know which medicine will work the best in the patient that is sitting in front of you? We've done this work and we saw that not all diabetics are the same. So what a physician does is they'll prescribe a medicine, try it out for a few months, and then come back, check their hemoglobin A1C or blood pressure, depending on what the situation is, and then they'll switch the medicine. So it takes about a year if you're tracking the patient real closely to find the right medicine in some of these patients, right? So, we went back and looked at the data on all diabetics and what are their medicines, where do they do well on which medicine. We found that there are several clusters of types of patients. So it's not just one kind of type 2 diabetes. There were 7 or 8 clusters, 4 big clusters. We knew that this patient, if their diabetes is not controlled, they'll have bad outcomes. And which medicine specifically works for which patient. I'm not saying that primary care should be the focus, the communication, the patient, changing their behavior, but you have a moral responsibility to find the best treatment for the patient. So on the physician side, I would say the technology is very helpful. Yeah. So that's point number one. Mm-hmm. Point number two, if technology can make people click on different things, and these big tech companies, they're making big money because they change your behavior, right? How long you spend. Can you use the same technology to change your behavior in your diet? Can you use the same technology to incentivize for people to walk? Can you decrease their insurance rates based on how many steps they took? These are all possible, right?
Of course.
That's where I think there's a big role for them.
Great. Excellent.
Yeah, even things like Ubering patients from the emergency room to the clinic. that is something that I can't tell you how many charts there must be, emergency room charts, where the emergency room physician has talked with one of the full risk doctors saying, the full risk doctor is saying the patient's hemodynamically stable and the patient can be managed in the outpatient setting. Here's the doctor's name, the doctor's cell phone number, and they're actually sending an Uber to the hospital to pick up the patient, send them to the outpatient clinic. I mean, the Uber ride costs how much? Dr. Aymara, you probably do it much more than I do these days. $7? $8?
Right about that.
Well, we used to send helicopters before. We actually did to move patients because it is cheaper to send a helicopter than a patient having
an emergency department visit and a hospitalization at an expensive hospial. Yeah,
well, yeah.
That's pretty crazy.
Remember my pneumonia? That's how much my pneumonia cost. The bill was $10,000. So yeah, I'm not surprised that helicopters are being used for a thing. And the treatment that they gave me cost less than $10 in the outpatient setting.
Right. Right.
I have a big bill story also like that. One time they said, "Would you approve this care that was provided at this university?" And I looked at the bill and it says $500,000 for this. Of course, it's a bleed in the brain, but $500,000, that's what I had to sign. Okay.
Wow.
Since we didn't have a bed.
Wow. Okay. And bringing this all back to where we began, we started talking about those sort of simple innovations that can make a big difference for patient outcomes and for cost of care. And we said the incentives that physicians operate under are very, very important. But we also talked about sort of patient communication channels. We talked about phone calls. We talked about text messages. We talked about the simple things, really. And in this world during COVID, in-person care was not safe because of infection risk. And so telemedicine, virtual care, and Faisel, you and I started talking about that on Fridays with Faisel, really exploded. And really what we see that as a benefit of just patient access, whether it's a geographic access problem, like from rural to urban, or not having enough primary care physicians in rural areas, but it's also access for people who might work 2 jobs and can't, go take 2 hours to go in person to the clinic, and being able to meet with that person in their living room, or somebody who can't get childcare and can't make it to the clinic and needs to see their doctor virtually. And those are things that I think are real tangible, like next step happening right now type innovations using technology. And they're fairly simple, as Faisel was saying at the beginning. FaceTime's not new, but it's new to healthcare to some extent. So I'd love to talk about that as kind of the final topic, to bring it back to what's going on right now in transitioning to some digital front door technologies and having patients access healthcare services via that medium. Does that work for everybody?
Yeah.
Who wants to go first?
Yeah, you can.
Dr. Fernandez.
You can let Dr.
Yeah, I mean, I have a lot of very joyful stories to share. I felt like virtual care has been a blessing for this. During this pandemic, I was able to access my 90-plus-year-old patients that I did not know they were so good with WhatsApp, pronounced in different ways, but they knew how to use it, and I was able to, make sure they didn't have any swelling in their legs or any rash. I did also have to advise some of my patients who work driving trucks that as much as I wanted to see them during their work, I did switch to phone calls, and sometimes I'm also a doctor who takes care of doctors and healthcare professionals. And this was and all kinds of professionals. And this was such an inviting opportunity for people who are trying to preserve their job to still have access to care, either at the comfort of their home or in the privacy of a small office space in their room. We are here to make it easy for seniors. I don't only take care of seniors, so we're here to make it easy for everyone. But I was amazed at how easily my senior patients adapted to this video era. I felt like I was a little, oh my God, no, it was perfect. And it's really been a blessing, and we still use it. Because there are some cases that, I still want to see you instead of like maybe, so we still use the video. This technology is here to stay. So I've definitely benefited from it.
Excellent.
Yeah, she brings up a good point. In our world, our average patient is 72, 74 years old, 5 to 7 chronic medical conditions. All of them are on fixed incomes of, I'm in the Tampa market, $600, $900 a month. And for this generation of people, the ones that we've been able to connect with the cell phone technology especially, they refer to it as, this is like the Jetsons. We've been waiting for this for like 50 years. Why did it take so long for it to come? And in fact, also another learning that I've had with my patients with telemedicine is that for this particular generation, they hardly FaceTime their kids. Maybe they do. If they FaceTime anyone, they'll FaceTime their children, but mostly they FaceTime their grandchildren. So it's a very intimate experience for the elderly population. So as the primary care doctor, now coming into the patient's home, in their home, they're able to show me what's in their fridge. There's a deeper connection, a deeper relationship. Like now I'm on the same level as many of my patients' grandchildren. Seriously.
Yeah. And Dr. Chettipally, any final comments on virtual care, on like digital tools that patients can access healthcare from?
Well, my first foray into entrepreneurship was I started this company where you can provide virtual care. And this was 1999.
Wow.
The internet wasn't even, the video technology wasn't there, where you can do that. But this was just messaging back and forth. It was that simple. So, the technology has always been there. The question is, will you use it, and as a physician or as an organization, use it? And if you use it, how will it affect the outcomes? Sometimes it could be just a text message. It doesn't necessarily have to be a video chat. I mean, video chat is great. It could be just an email, where you're saying, hey, I got better with this dosage. Should I stop this medicine? Things like that, simple things, right?
Mm-hmm.
But definitely, video has and the technology has definitely improved. As long as we have the business models that will support this, it will be great. Now, imagine
Right.
in a fee-for-service world, let's say they'll say, "Oh, we'll not reimburse you for this video visit." It's gone.
Right.
Nobody will do video visits. Of course, the patients will feel very sad because now they cannot use it. But that's the scary part about
Mm-hmm. Right.
financing of how healthcare companies work.
And bringing it back to, you have the incentives in the system, you have the payment models that really do influence behavior of physicians and of practices and of other healthcare delivery organizations. And when you change those, then you start to get a lot of innovation occurring, whether it's small innovation, whether it's just texting your patient, or whether it's the use of artificial intelligence and behavior change technologies that are delivered via smartphone. And I think that that's what's really exciting about healthcare going forward. And I'm very excited to talk with everybody here about this topic. I think that this is where we're going to see things go, and it's very positive. We're in a period of healthcare that's really got everybody down, from the system to the physicians to the patients, and we can really only go up from here. So thank you all for sharing your expertise today.
And let's bring Dr. Dan back. Dr. Dan, please come back. Dr. Dan has been manning the comment section. Thank you so much, Dr. Dan. That was fun. How was it?
Good. Lots of good comments, and so I was trying to keep up, but I think you all did a great job covering all the information, and obviously more than we can do in 1 hour, but it was great.
Super. And Dr. Uli, thank you so much for joining us this week. We really appreciate you being so nimble. I look forward to having you come back again.
Sure, I would love to. Can I plug in one conference that I'm doing for physician innovators?
Sure.
Please go to innovatormd.com. In January, we are doing this largest physician innovation conference. So
we'll make sure to definitely post it on the LinkedIn. We'll make sure on the LinkedIn post, when we post this discussion we had today, we'll make sure to put that there.
And all of you guys are welcome to participate, even speak.
Oh, super.
Right.
Dr. Aymara, thank you so much for joining from the clinic. I know that you're in between seeing patients. Thank you so much for taking the time to come join us today.
Thank you. Thank you for the opportunity and for the learning, and truly believe in what we're doing. Thank you. I
can't wait to have you come back as well. I think it's really important that as many people are debating how to transition from fee-for-service towards value, and even with us, like, we really are we're at the extreme in the full risk model. I think your voice and our doctors' voices who are living this full risk model, I think it's a powerful voice. It's a reality check for people who are completely lost. And to anyone who participated in the chat, thank you so much for joining us. Anyone who was listening, thank you as well. Thank you so much for joining us. For more information about what we discussed today, as well as value-based care in general, please visit chenmed.com/resources. We believe healthcare is a right, not a privilege.